So today we're going to be talking about oculodynia, and basically it's pain which you feel in your eye that's precipitated by the light. So as you know, the light, the photo, can be fear of the light, like photophobia, or you can just be sensitive to the light, photosensitive. And a lot of work has been done recently trying to elucidate the pathways for both photophobia and photosensitivity, including the probable pathogenesis of photooculodynia. So as you know, the light sensitive structures, the light comes into the eye, hits the retina, ganglion cell, and down the optic nerve. And it's here where it's an integration of the light and the pain pathways that causes the problems that we see. So around the carotid artery, we have the sympathetic nervous system. We have the dura of the brain, which is a pain-sensitive structure. And that means the trigeminal is going to be involved in the afferent side on the pain side. And so the mixing of the afferent pathway from the optic nerve, cranial nerve 2, with the afferent pathway sensory on the trigeminal is where these photophobia, photosensitivity problems come into play. And so the trigeminal, of course, is going to send that information to the thalamus to be mediated, and then you're going to feel the pain in your cortex. So it is a trigeminal thalamic tract. There's integration of the pain signal coordinated with the light. And so the first job of an ophthalmologist is to make sure it's not coming from your eye. So the pain-sensitive structures, again, trigeminal, V1, is going to be innervating the cornea, so dry eye, uveitis. These are the pain-sensitive things. Optic neuritis, even though it's on the optic nerve, that's carried by the trigeminal, so that's why the pain is with eye movement. And so when we have the combination of photophobia and photosensitivity, the first thing is to make sure the afferent pathway is intact on cranial nerve number 2, as well as the pre-optic nerve pathway, the intraocular pathway. So both the intraocular pathway has to be normal and the optic nerve has to be normal before you make the diagnosis of the idiopathic variety, photooculodynia. The patients with photooculodynia often have dry eye symptoms, again trigeminal based, without having very much dry eye signs. And they might come in with 2 or 3 pairs of sunglasses on, because they're so sensitive to the light. And even though photophobia and photosensitivity occur in patients who have optic neuritis, this is a kind of an uncommon symptom to have. It usually means that there's something wrong on the trigeminal side. In the literature, the sunglass sign normally implies that the person is non-organic. But what if they don't have any vision loss and they're wearing the sunglass? Then I don't think we should apply the sunglass sign to people whose complaint is not afferent related on the visual side. They might actually be photophobic. They might actually be photosensitive. So before we go to photooculodynia, you need to know about the pain-sensitive structures. So the dura, subarachnoid hemorrhage, meningitis can present with patients sometimes have photosensitivity. Anything that affects the trigeminal or the thalamic system. And so we need to make sure the eye exam is totally normal before we call it photooculodynia. Once we've made sure the eye exam is normal, the patients with the photooculodynia, this is a diagnosis of exclusion. So you can't have anything else. You can't have any finding. The dry eye symptoms seem to predominate. The pain seems to predominate. It's localized in the trigeminal distribution, and the light is the trigger. If you have made the diagnosis clinically based on these criteria, then we can treat. We can use teardrops to make people feel better. We can use medications, including the neuropathic pain medications. We can give botulinum toxin, which is the same thing we're using for migraine. And you can use all the migraine medicines as well. Interestingly, migraine also has a similar pathway. Migraine patients are often photophobia and have sensitivity to light, have to go lie down in a dark room with a cold washcloth on their head. Migraine patients are thought to have pain mediated through this trigeminal thalamic system. So there are clear analogies between what we call photooculodynia and migraine, even though they're probably not the same disorder. And because not all the wavelengths are the triggers, we tend to favor using FL41. I have no proprietary interest. But there are other filters that can be used, and it's kind of a trial and error process. But FL41, the rose tilted glasses, is the only one that was really studied well in a clinical trial, and it has been shown to be effective and is the most likely one to be of benefit, so they don't have to wear the 3 pairs of sunglasses. They're only sensitive to very specific wavelengths. It's just a matter of finding that wavelength. If botulinum toxin injections don't work, Botox, we can do other injections. If the trigger point is in the greater occipital nerve, you can do a greater occipital nerve block. And for photooculodynia, if they fail maximal medical therapy and the easy injections, we can do a stellate ganglion block. That also was looked at in an open trial, and was because of this sympathetic nervous system component, we can block here in the stellate ganglion. So photooculodynia, pain, eye, sensitive to light. Make sure it's not the dry eye. The patients often have dry eye symptoms. Make sure the afferent system is intact. The diagnosis of exclusion, often wearing multiple pairs of sunglasses. Switch to FL41. Try the medical therapies first. Try the migraine therapies first, including Botox. And if all else fails, a stellate ganglion block.